All right, everybody, welcome back to another episode here at WhiteBoard Medicine. We appreciate you checking it out. Today's episode is going to be one of those classic critical care topics, and it's going to be an introduction to vasopressors and inotropes. This is a foundation, absolutely mission critical concept for anybody working in the emergency department, critical care unit, students, trainees, nurses, docs, PAs, MPs, the whole gambit, or anyone just interested in this topic, because this is a really interesting topic. So we're going to start with an overview. We're going to dive into what vasopressors and inotropes are. We're going to be talking about each individual one, their mechanisms, when to use them, all that good stuff. A couple shout outs quick before we dive in. One is this study guide, as well as all of our study guides and practice questions are going to be posted to our YouTube members page, as well as our Patreon members page. We'd love for you to join us if you have the interest or ability. Obviously, we'd be super grateful for the support in that sense too. We also have a free weekly newsletter that focuses mostly on public health and emerging infectious disease. All that is linked in the description. You might be looking at this on YouTube. You might be listening to this in podcast format. So we both have podcasts and YouTube platforms too, for anyone interested. And then last thing, as we always say, this is not intended to be acted upon as medical advice. Listen to the end of the episode for the full disclaimer, or read it in the description. Great. Enough shout outs. Hopefully everybody is still with us and eager to dive in. Vasopressors and inotropes. So just starting with an overview. What are these things? Let's get our terminology and definitions right. Vasopressors are medications that induce vasoconstriction, and as doing so, they elevate the mean arterial pressure, the MAP. They're primarily used in shock states, and the goal is to maintain organ perfusion. So patients often, when they're hypotensive, we give them a vasopressor to vasoconstrict and increase their MAP to maintain organ perfusion. This is different than inotropes, okay? Inotropes actually increase myocardial contractility, right? The squeeze of the heart muscle. And this helps in low cardiac output states like cardiogenic shock or decompensated heart failure to improve the squeeze of the heart, improve the cardiac output, and improve organ perfusion. So these are two very different therapies, but they're two that we often need to try to optimize organ perfusion. So in critical care, the line between vasopressor and inotrope often blurs because many vasopressors have inotropic effects, which we'll talk about, but it doesn't work the other way. Most inotropes do not have, don't have vasoconstriction effects. Most of them actually vasodilate, which again, we'll talk more about. Key vasopressors and inotropes at a glance. So this is going to be a table that has kind of that classic setup of vasopressors and inotropes, and I'm going to talk about each one. We have drug, we then have receptor activity, predominant effect, and typical use. And we'll be reinforcing this because we're going to talk about each one in more detail. So norepinephrine, also known as Levophed, this is our workhorse of vasopressors, right? This vasopressor primarily has alpha-1 activity. Anytime you see alpha-1 causes vasoconstriction of the peripheral vasculature. Okay, this is a vasoconstrictor. It increases your systemic vascular resistance. It increases your MAP. So norepinephrine primarily has alpha-1 effect. It does have slight beta-1 effect. Beta-1 actually increases your heart squeeze, okay? It's on the heart muscle, and it helps with cardiac output. It's a little inotropic, right? So alpha-1 vasoconstrictor, vasopressor, beta-1, a little inotropic, heart squeeze. So norepinephrine, alpha-1 greater than beta-1, all right? And we use it predominantly for vasoconstriction and to increase the MAP. And it is the first-line vasopressor for septic shock, any distributive shock states. Some literature even suggests it's a good vasopressor for cardiogenic shock. Really, norepinephrine or Levophed is the first-line vasopressor for any shock state until you have a little more information. There's certainly some nuance here, and maybe we'll come up with a video of the nuances as well, but that's a very advanced topic. So the basics would say norepinephrine is first-line vasopressor for patients in shock. Norepinephrine's cousin here is epinephrine. Okay, epinephrine has a dose-dependent relationship with its receptors, and we'll get into the details of what doses do what. But epinephrine, depending on the dose, has either beta-1, right? So this is heart squeeze, beta-2, which actually is a vasodilator, or alpha-1, which is a vasoconstrictor. So beta-1, beta 2, or alpha 1, depending on the dose. And as such, the predominant effect, if it's beta 1, it's going to be increasing cardiac output because beta 1 is kind of inotropic. It increases heart squeeze. Whereas if the dose is alpha 1, it's a vasoconstrictor. So that's a predominant effect, either increased cardiac output or vasoconstrict, depending on the dose of epinephrine. Its typical use, it is first line in anaphylaxis. Anyone with anaphylaxis should get epinephrine. Absolutely first line. EpiPens, right? That's what people carry around who have known anaphylactic allergies. You also give it in cardiac arrest. And, you know, it's one of those that you could consider in septic shock, but is not first line. Dopamine. Dopamine's no longer really used, but we'll talk about it briefly. It is another dose-dependent vasopressor, where it at lower doses affects the dopamine receptors. The old adage was this helped renal perfusion, but this has kind of been proven not to be effective. And then it has beta 1 effects, so it can help with cardiac output, and alpha 1 effects. So its predominant effect is inotropy, increasing cardiac output, or vasoconstriction. The thing here is that it was studied against norepinephrine, and norepinephrine was much better, which is why dopamine isn't really used. A time when you might see it, which isn't unreasonable, is for patients who are bradycardic, because it does have an increase in chronotropy being increasing the heart rate. So bradycardia, dopamine is not unreasonable. I think most people probably use epinephrine, even for bradycardia, but that might be a time you see dopamine. But for shock, dopamine is no longer recommended. People aren't using, well, I shouldn't say that, but the expert consensus would suggest that dopamine shouldn't be used for shock. All right, next, our friend phenylephrine, or neosynephrine is a brand name. This is only alpha 1, so there's no beta 1 effects. This is all alpha 1, all vasoconstriction. It's a pure peripheral vasoconstrictor, and it can be used for hypotension, especially in patients who have been having tachydysrhythmias. All right, so tachydysrhythmias have an increased incidence when any of these vasopressors are affecting the heart, if any of them have beta 1 activity. So norepinephrine, although it has primarily alpha 1, it does have some beta 1, right? So it increases the risk of tachyarrhythmias. Epinephrine certainly has beta 1, increased risk of tachydysrhythmias. So phenylephrine can be used for hypotension with tachydysrhythmias. You know, I'll be honest, the literature on norepinephrine really causing tachydysrhythmias, you know, it does, but not a lot of folks switch from norepinephrine to phenylephrine just for tachydysrhythmias alone. Some people do, but the evidence there is a little bit gray, but you will see it. But phenylephrine is a alpha 1 only pure vasoconstrictor. Vasopressin, our friend vasopressin. This is a non-catecholaminergic or non-adrenergic vasopressor. So the other ones we talked about, norepinephrine, epinephrine, dopamine, and phenylephrine, are all catecholaminergic or adrenergic. They all use catecholamines, alpha 1 receptors, beta 1, beta 2, all these receptors that are sensitive to catecholamines. Vasopressin is a completely different mechanism. It uses the V1 receptor. This V1 receptor causes vasoconstriction, and it's an adjunct vasopressor in septic shock. So recommendations would suggest that in patients on norepinephrine to a certain dose, which we'll talk about, you could consider adding vasopressin. Usually it's static dose, 0.03 units per minute. Some places use 0.04. I think it's units per minute. Yeah, it's not hours per minute. So vasopressin is an adjunct, non-adrenergic vasopressor. The other nice thing about vasopressin is it doesn't cause pulmonary vasoconstriction. So patients with right heart failure sometimes like vasopressin a little bit more because it will not constrict their pulmonary vasculature, which when you constrict your pulmonary vasculature in someone with right heart dysfunction, that increases the stress on the right ventricle and can cause worsening symptoms. Dobutamine and milrinone, these are pure inotropes, okay? So dobutamine works on beta 1 receptors. It increases contractility and actually has some beta 2 effect, which if you remember, beta 2 causes vasodilation, alpha 1 vasoconstriction, beta 2 vasodilation. So dobutamine causes increased inotropy, increased cardiac output, increased squeeze, all those are synonyms, but then mild vasodilation. So it can actually drop your map a little bit. This is good for cardiogenic shock and heart failure, right, where you just need to increase your cardiac output through increasing your squeeze. Milrinone actually works on the PDE3 receptor, phosphodiesterase 3, and it causes increased inotropy, which again, synonyms: increased contractility, increased cardiac output, all those are the same. And it also causes vasodilation, so it'll drop your MAP a little bit. Also good in cardiogenic shock and decompensated heart failure. Milrinone is renally excreted. So when they study these head to head, they probably work the same, and some evidence suggests milrinone is okay to use in patients with renal injury, but it is renally excreted. So you don't really know what dose is in the blood in patients with really bad renal failure because you don't know how much they've peed out or not. So dobutamine is sometimes a better choice in patients with severe renal dysfunction, although there's lots of debate about that. All right, so dobutamine, milrinone, these are inotropes primarily, so they cause increased inotropy, and they actually both cause vasodilation. Vasopressin is a non-adrenergic vasoconstrictor. Phenylephrine, dopamine, epinephrine, and norepinephrine are all adrenergic or catecholaminergic vasopressors. Phenylephrine is just alpha-1 vasoconstrictor. It has no beta-1 or heart effects, whereas epinephrine does have beta-1 heart effects, increasing contractility, and norepinephrine has some beta-1 but is mostly alpha-1. All right, we're going to dive into all these even more. Let's tease it out. Let's test ourselves. So starting with norepinephrine, we had that whole table up there, which was probably confusing, but at least laid it all out in one place. We're now going to talk about each individual one. So norepinephrine, as we said, is primarily an alpha-1 receptor vasoconstrictor with some beta-1, which is inotropy or contractility. So the mechanism of action is norepinephrine causes alpha-1 mediated vasoconstriction, which increases the systemic vascular resistance and it increases the mean arterial pressure, and it has some mild beta-1 effects which increase the heart rate and increase contractility. And this is absolutely first line in septic shock and most shock states. Epinephrine. It is dose dependent, right? So at lower doses, epinephrine actually is mostly beta-1 and beta-2. So it mostly causes increased heart rate, increased inotropy or contractility, and then vasodilation. Remember, heart rate and inotropy is beta-1, vasodilation is beta-2. So at low doses of epinephrine, around less than 0.1 micrograms per kilogram per minute. So for a 100 kilogram person, that'd be less than 10 micrograms per minute, and this is an estimate. It is primarily affects the heart. It primarily increases heart rate, increases inotropy, and then causes some vasodilation. So someone who's bradycardic, you can put them on just static dosed epi, epi at whatever you want, 5 micrograms per minute, so low dose, and then that will increase their heart rate, increase inotropy, but it will cause a little vasodilation. Whereas higher doses of epinephrine then start to have primarily alpha-1 vasoconstriction effects. So anything above that 10 micrograms per minute starts to have less inotropy and more vasoconstricting effects. So this is first line in anaphylaxis, also in cardiac arrest, and then refractory shock after you've already put them on norepinephrine. Epinephrine is sometimes what people grab. If you really want to be, super thoughtful and elegant about this, sometimes patients who you think are in septic shock with a little bit of a suppressed ejection fraction, sometimes these patients like epinephrine just because you have more of that beta-1 effect, a little more inotropy. But again, norepinephrine is first line. Dopamine, I don't know if it's even worth talking about it, but I suppose we still will. Dopamine is not used. Use is rare. But it is another dose-dependent drug. So very low doses, less than 5 micrograms per kilogram per minute, which for a 100 kilogram person would be 5 micrograms per minute. Okay, it primarily works on this dopamine receptor, which causes renal vasodilation. It was thought to be quote-unquote renal protectant, but it is not recommended anymore. It does not seem to do that in a meaningful way. Moderate doses, 5 to 10 micrograms per minute, is primarily beta-1. Beta-1, remember we said, is contractility or inotropy, so it'll increase heart rate, increase the squeeze of the heart. And then higher doses, greater than 10 micrograms per minute, is primarily alpha-1 vasoconstriction. So dopamine, like epinephrine, has this dose-dependent response. Again, the time you might see dopamine used is for bradycardia, which would be static, low dose. You just said it at something like 2 micrograms per minute. Anything less than 5 mics per kg per minute. Oh, this is supposed to be less than 0.5. So Dopamine in general increases arrhythmias, is less reliable for MAP control, and when they studied it compared to norepinephrine, outcomes were worse in dopamine, so we do not use dopamine anymore. At least we shouldn't be if it is being used. All right, phenylephrine. This is that pure alpha-1, pure vasoconstriction, increasing SVR, increasing MAP. It has no heart effect, and it's good for hypotension with tachycardia, maybe. Spinal shock is a good one, so patients in neurogenic shock from a high spinal cord injury, phenylephrine is sometimes great for them because they just need that vasoconstriction, that increased SVR. Also sometimes LVOT, left ventricular outflow tract obstruction, when you want to increase the MAP, but you don't want to increase the heart rate because increasing the heart rate leads to less filling time of the left ventricle, which can worsen a left ventricular outflow tract obstruction. This is somewhat of an advanced topic. Maybe we'll put a video out on LVOT obstruction. Let us know if that's something you might be interested in. That'd be an interesting topic. But phenylephrine, I think for spinal shock and LVOT obstruction can be really good. We don't tend to use phenylephrine in other situations, even hypotension with tachycardia. We don't tend to use phenylephrine unless some really significance going on. We still tend to use norepinephrine. Vasopressin, this is one of those non-adrenergic or non-catecholaminergic vasopressors. It acts on this V1 receptor, which is on vascular smooth muscle, leading to vasoconstriction outside of the adrenergic pathway. It also leads to water retention via the V2 receptor in the kidneys. It's an adjunct in septic shock, so when you have septic shock, you're on norepinephrine and you get to higher doses. What exactly that dose is somewhat debated, but somewhere, between probably a 0.15, 0.25 micrograms per kilogram per hour. A lot of people add vasopressin. It's usually static dose, either 0.03 or 0.04, depending on the institution you work at. People say it works well in acidotic states. We've never verified this fact, but that is what people say. And then catecholaminergic kind of failure. Some patients are very vasopressin responsive. So there's this whole kind of entity of the vasopressin deplete state, especially in septic shock, sometimes even hemorrhagic shock, where your body uses up all of its vasopressin stores, and then you are very sensitive. You respond really well to vasopressin because we are essentially replenishing what is the person's vasopressin stores that they have run out of because they used it all because they're critically ill. So that's something to keep in mind, that some people are very vasopressin responsive and do really well with it. Dobutamine. This is an inotrope, as we talked about. It works on the beta-1 receptor. Remember, beta-1, inotrope, alpha-1, vasoconstriction. There is mild beta-2 effects. Remember, we said beta-2 is a vasodilator. All right? So the mechanism is increases inotropy and heart rate through the beta-1 effects. It causes mild vasodilation through the beta-2 effects, and this increases cardiac output, but it can decrease the MAP, which is okay. Sometimes you just need to add norepinephrine to it if it's dropping your MAP. This use is for low output heart failure and cardiogenic shock, certainly. They say especially if blood pressure is greater than 90, but if you need norepinephrine, that's fine. If you got to increase the cardiac output and you got to use dobutamine, you have to, independent of what the blood pressure is. It might worsen hypotension due to vasodilation, so just be aware that that's going to happen and plan for it. Milrinone, our other inotrope. This is a phosphodiesterase 3 inhibitor, PDE3 inhibitor. Inhibits the PDE3, which if we go down the pathway here is going to increase C-AMP, increase calcium in cardiac myocytes, which will increase contractility. We say calcium, is nature's inopressor. So increasing that calcium in the cardiac myocytes is going to increase contractility. It does cause vasodilation in smooth muscle, just like dobutamine causes vasodilation. So the effect is increased inotropy, increased cardiac output, decreasing SVR, decreases MAP, and this can decrease pulmonary vascular resistance, which is nice too. This helps out the right heart as well. So good use in decompensated heart failure, right heart failure, cardiogenic shock. It does work slower than dobutamine, and it is renally cleared. So when someone has really bad renal injury, you're not quite sure how much milrinone is circulating in their body at any one time. And then just like dobutamine, these inotropes can increase risk of arrhythmias, as can anything that does increase contractility. So here's just a dosing reference. Take it all with a grain of salt. These are some dose suggestions, but all this is context dependent. Every institution has their own dosing recommendations, so certainly check out what that is, but this just gives you some context of certain doses. I think something that is important is you always start low and you titrate. Our nurses spoil us and they usually titrate these themselves. If it's an inotrope like Dobutamine or milrinone, you're using it to increase cardiac output. Sometimes you're looking at perfusion goals, or if you have a pulmonary artery catheter, a SWAN, you can look at cardiac index, all that good stuff. Whereas for pure vasopressors like norepinephrine or epinephrine or phenylephrine or vasopressin, you're really targeting a MAP of 65, as we've talked about in different shock videos in our critical care playlist if you're interested. When we monitor, we need to monitor these patients thinking about the things we are doing that we're using the vasopressor inotrope for. So if we're doing it to protect the MAP, we need to monitor the MAP is 65. If we're doing it to increase the heart rate, we got to monitor the heart rate. Obviously, we're looking to increase organ perfusion, so watching urine output can be important. If it's an inotrope and you're doing it to increase cardiac output, you should really think about the cardiac output, cardiac index. Do you have a SWAN in? Labs we track, lactic acid, renal function. Some people talk about troponin. And then arrhythmia surveillance is important. These medications can increase risk for arrhythmias. Any of them can, really. Epi, any of them with beta effect. Epi can, norepinephrine can. Certainly dobutamine, certainly milrinone. Dopamine definitely does, although hopefully we're not using that really anymore. The ones that don't increase arrhythmias are going to be phenylephrine and vasopressin. Don't increase arrhythmias because they're not catecholinergic drugs. Peripheral IV risk, many of these medications need a central line, although there are peripheral vasopressor guidelines specifically for norepinephrine that people can look up or ask us about. If it is peripheral, you risk extravasation, which can cause necrosis, although there's medications to reverse this, and the risk is low, but it is possible. Contraindications, caveats, we're getting towards the end here. So all of these medications are really powerful medications. They all have risks. So norepinephrine, you can get digital ischemia at high doses. Epinephrine, increased tachydysrhythmias. Epinephrine does increase the lactic acid level too, not by a ton, but it does a little bit, so just be aware of that. Dopamine is pro-arrhythmic, and it's a steroid drug. I'm crossing it out again. Phenylephrine. Phenylephrine can decrease your cardiac output, especially in cardiogenic shock, because it's pure alpha-1, right? So it's a pure vasoconstrictor. It increases your systemic vascular resistance, your SVR, which is essentially your afterload that the heart is squeezing against. So if you have a weak heart and it's squeezing against a higher afterload, its output's going to be lower. So you don't want to use phenylephrine in patients with a bad heart. There's some valvular things where it can be helpful, but in general, weak hearts don't like phenylephrine. Vasopressin can increase risk of ischemia, especially in the gut. Dobutamine can increase hypotension. Milrinone, renally excreted, long half-life, can also increase hypotension risk. So all of them have different contraindications and caveats. So last but not least, clinical pearls. The things that are most important, the summary here is norepinephrine is the vasopressor of choice in most cases of shock. When in doubt, grab for norepinephrine. Epinephrine can be ideal if there's both cardiac needs and vasopressor needs. Anaphylaxis, it is certainly first line. Dobutamine and milrinone are preferred for cardiogenic shock, but monitor and prepare for hypotension. Milrinone can be particularly helpful in right ventricular failure or pulmonary hypertension because it has that further decrease in pulmonary vascular resistance, which is the afterload of the right ventricle. Vasopressin reduces your norepinephrine requirements and augments MAP when there's refractory distributive shock, so it's an adjunct to norepinephrine in septic shock. And then avoid dopamine in general. It's associated with increased mortality. Here's a summary table. We're not going to read all this out loud. We just want you to have it here for your own reference. Again, this will be uploaded to our YouTube members and our Patreon page if you want access to this study guide. That's all we have for you today. Really basic introductory stuff. Let us know your thoughts, comments, questions. We would love to know what you're most interested in, and we can dive into some of the nuance as you all see fit. So definitely let us know. Subscribe, hit the bell button, check out our other stuff. We appreciate y'all. Stay well, keep learning. We'll see you next time. Hey everybody, and welcome to WhiteBoard Medicine. We appreciate you checking out the video. Here at WhiteBoard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.